LPP and FA are the same disease or are distinct entities?
I would say that are distinct entities. The whole course, prognosis, and treatment are different.
We cannot really treat them with algorithm. We have to listen to them, to their needs, their expectation. So, good morning to everyone. We are very happy to be here with the Hair Task Force of the EADV. It's a great pleasure for all of us to stay here. I'm Michela Starace. I'm the chair of this task force, and together with my co-chair, Professor Alexander Katoulis and Dr. Matilde Iorizzo, we are here to talk about lichen planopilaris, and we would like to understand and to explain from the basis to the new management. It's a great pleasure to introduce my co-chair. I start with Dr. Iorizzo, that is a Swiss-based dermatovenerologist specialized in hair and nail disease for a lot of years. It's more than 20 years, also for friend, also for great experience. And she is a lecturer at the USI Faculty of Biomedical Science in Lugano and a consultant for hair and nail disorder at the Dermatology Department of Cantonal Hospital in Bellinzona. She is absolutely a great author of a lot of papers that are published in international national journal, and also she is with us chair of this task force. And my other co-chair is Professor Alexander Katoulis, that is a professor and chairman of the second Department of Dermatology and Venereology at the National Kapodistrian, I hope that is correct, University of Athens, Medical School and based at Attikon General University Hospital. Is also the director of the postgraduate program of the NKUA, Updated Diagnostic and Dermatology and Allergology. So, welcome with me in this new podcast.
Happy to be with you in this EADV podcast.
Same for me, Michela. Thank you. Thank you, thank you. I hope that this podcast will be very useful for all the audience. And we start with a few questions. First of all, I would like to start to introduce Professor Katoulis about especially the basis of LPP. So we start with the first question about the definition and nosological spectrum of LPP. What do you think? What you want to share with us?
Yes. I think definition is very important in every disease. So, lichen planopilaris is a chronic inflammatory primary scarring alopecia characterized by a lymphocytic lichenoid inflammatory infiltrate targeting the hair follicles. It was described in 1985 as a variant of lichen planus. Uh, as I mentioned, it is a primary scarring alopecia, meaning that the inflammatory infiltrate targets the upper hair follicle where the reside the stem cells of the hair follicle, and the destruction of this result in permanent alopecia. The problem is that mostly primary alopecias are described on an histopathologic basis, but patients are clinical cases. So it is important to realize that we have to deal with a nosological spectrum and not just a disease. And this is true, especially regarding frontal fibrosing alopecia. Frontal fibrosing alopecia was described as a variant of lichen planopilaris by Cossart in 1997. And this continuously reappears in every paper. And I think that this is misleading because these are two different diseases in the same nosological spectrum. Uh, they have a common histopathological background, but on the other hand, the clinical presentation is completely different. One is patchy alopecia, the other is a patterned alopecia. Uh, the epidemiology is different because there are middle-aged, most of the patients of lichen planopilaris. Men are more, women are more prevalent, but men also often are affected, while in frontal fibrosing alopecia uh, predominate the postmenopausal women, and even uh, women with early menopause or iatrogenic menopause are affected. So also the pathogenesis, considering the androgens, may be different because frontal fibrosing alopecia uh, affects androgen-dependent area of the frontal scalp and has this epidemiology, and the treatment with uh, 5A reductase inhibitors is very effective. Uh, and I would say that also genetics are different. In every aspect, there are differences. So I would say that we should consider that this lichenoid uh, inflammatory scarring alopecias, and I will include also the fibrosing alopecia in a pattern distribution, are branches of the same pathobiologic tree where there is a lichenoid folliculitis extended also to the interfollicular epidermis with a lichenoid infiltrate. Uh, as I said, that targets the stem cells and results in a permanent alopecia.
So, in fact, my question was about our paper. It is also the first paper that the task force published about this possibility if FFA is an entity or it is a spectrum of the LPP. And at the end, if you want to, if someone asked you at the end, what do you think? LPP and FA are the same disease or are distinct entities? What is your question? If you have to select at the end.
I would say that are distinct entities, and I would say this because the whole course, prognosis, and treatment are different. Even the diagnosis is based on different aspects. I believe that you will mention them um, later. Uh, I think that to consider them as the same disease does not help uh, the successful management of the patient. It's not an obsession to find an answer, but to this question. But what is better for the patient? And I think it is better to consider it as a distinct disease. And I would say an example: if we consider it the same disease, uh, we would think that a good alternative for frontal fibrosing alopecia uh, is hydroxychloroquine. And this is not as effective as 5A reductase inhibitors because the inflammation in frontal fibrosing alopecia is minimal compared to the lichen planopilaris. So the whole treatment approach, in my opinion, is uh, almost completely different.
So at the end, maybe they are two different pathology, two different disease in the same spectrum, because the infiltrate is also lymphocytic infiltrate, so it is not a difference. So maybe the spectrum can be together is the point of the association of the two entities. And I think we can move versus the diagnosis. So what do you think, Matilde?
Yes, I have a curiosity, a particular
Yes,
question
sure.
for you that are the dermoscopy expert. So I'm curious about your opinion about the use of trichoscopy in LPP. How do you use trichoscopy? So how important is trichoscopy for the diagnosis of LPP, for the choice of therapy? How do you
Thank you. I think today it is very important, this definition, and we can follow at the end the conclusion that there are different entities but the same spectrum, because also in trichoscopy we can see the same alteration. The same trichoscopy sign are very similar, even if they are in a different point, in a different part of the scalp. But it is very important to recognize them, because with the use of trichoscopy, we can decide then the therapy. So it's important to understand if it is an activity, and we have to recognize the presence of peripillar hyperkeratosis, so this perifollicular, that can be also hair cast. That is this desquamation, very strong desquamation all around the follicle that induce the destruction of the hair follicle too. Then we can have also, if the inflammation is not so high, it's not so great, it is possible to have this pili that is a very not regular aspect of the hair shaft. And it's important also to recognize the color alteration, because you have this patchy area, a white area where there is already a cicatricial heart, versus the red zone where there is an inflammation. And I think this important sign can follow us to decide the therapy, maybe more conservative, because unfortunately we can arrive too late, and there is also a cicatricial part, versus the activity, because all of us know very well that the decision, the choice, the goal in cicatricial alopecia is to stop. It is impossible to regrowing. And for this reason, you have to recognize as soon as possible when there is an inflammation, and to stop it with a selected therapy. And we know that there are a lot of traditional therapy, but in the recent year, there is a new entity, in this case is a new possibility. And I would like absolutely to use your great experience about the new therapy. And in the recent year, you know that JAK inhibitors have attracted a lot of very high attention to the possibility not to be so selective versus alopecia areata, but also with other diseases. And one of these is also LPP. What is, in your opinion, Matilde, the possibility to use this drug for what reason? What is your important expert opinion about it?
Thank you, Michela. So first of all, I want to say that the treatment armamentarium for lichen planopilaris is limited. Some drugs works very well, others not, and also depends on patient, on the degree of inflammation, and there are no approved medication for lichen planopilaris. So we use experience, case series, case report, but there are no trials with medication for lichen planopilaris that led to an approval of a drug. JAK inhibitors are a quite new medications and approved for some conditions and used off label for other conditions. And of course, why they are considered, they could be an option in lichen planopilaris, their rationale is in the disease biology, basically. So it has been said that the inflammation is mainly by lymphocytes, and the hair follicle immune privilege is broken down by a T cell mediated attack with interferon gamma and JAK, Janus kinase, STAT signaling play a key role. So basically, if you inhibit this signaling, you can block or at least reduce the inflammatory infiltrate and the attack on the hair follicle. So JAK inhibitors are not able to revert the scarring. This is something that we cannot do with this drug. And the evidence about these drugs comes from case reports and small series using both topical and JAK inhibitors, including tofacitinib, baricitinib, upadacitinib. There are a lot of them nowadays. And in approximately 60% of reported cases, patient experience reduction in symptoms, so itching and burning, and stabilization of hair loss, and in some instances, even modest regrowth if they are used in early phases. What I want to underline, however, is that the numbers are limited, so we cannot draw definitive conclusion. They seem a promise new drugs to add in the armamentarium, and even in their topical forms, maybe the topicals can be a safer alternative to oral drugs and also less expensive. And since the treatment remains difficult, one of the objectives of the task force this year has been to put in a consensus on treatment, trying to provide to the readers, to the dermatologists, a kind of algorithm of treatment. That I would also say that patients are human being, so we cannot really treat them with algorithm. We have to listen to them, to their needs, their expectation, but the consensus was to act as a guide, as a skeleton to give physicians idea on how to proceed.
And for your experience, because in also in Switzerland you use a lot of these JAK inhibitors. In these cases, we can maybe in the future we can use JAK inhibitors in LPP as in the same evaluation of alopecia areata, so never as a first line, but in these cases, we have no time to for blocking the inflammation. And do you think there is maybe in the future possibility to start immediately? It is better always to start with the traditional, and after how many time? A few months. So, what do you think it is the best approach? Maybe in a hypothetical future.
That's a very difficult question to answer because they cost a lot. So they are very expensive and they are off label. So patients cannot cover the cost. So sometimes you are forced to start with a traditional treatment because of this. And also, we don't have yet a kind of guideline on how to keep going with the dose, if we can reduce the dose over time. So the risk is that at present, for the knowledge that we have, is that we start with high dose and keep the patient with high dose forever because we don't have the knowledge. So that's why there are too many things that we don't know yet to reply to this question.
So I think that LPP it's a great argument that also the task force have to be inside. So maybe in the future, especially with our expertise, we need maybe to have a review. What do you think, Alexander, to understand the role of this therapy? Also because you are very expert about pathogenesis, so do you think there is a new possibility to use JAK inhibitors, or what do you think?
I think what we can do with JAK inhibitors in LPP is to use them as a long-term therapy, because for acute flares we do well with corticosteroids. We don't need them for the acute flare. Uh, we can use them as a better anti-inflammatory for long-term use to prevent further relapses, uh, in the way we use them in alopecia areata. So I don't know how this could be proven the the efficacy if we're not able to use them in the first place. But in my eyes, the role of JAK inhibitors in scarring alopecia is a long-term treatments to subside the whole inflammatory process and prevent further scarring.
Perfect. So we needed to have a new appointment, maybe next year, like this, with this new entity. We hope that we can answer also all our doubt. I think so. With this, I think we can say hello to all the audience about, and we would like to thanks all of them to stay with us in this podcast about LPP. And again, thank you so much, Professor Katoulis and Dr. Iorizzo, to share this task force with me and to be here all together.